Yes,
Yeah,
yes, yes.
thank you. Thank you, Endocrine Society, for inviting me to this Endocrine Society Obesity Week program. And the task given to me is about discussing about the recent advances in medical management. And I will focus more on the recent advances, but I will discuss in brief about the current and other emerging treatment options also. So the agenda will be in this form that what are the lessons learned from the medication in the past, currently approved medication for short-term use and long-term use. What are the current available medication, although they are not approved, but they are possibility in the use for obesity management and future pharmacotherapy? That will be an interesting discussion. So as we have already discussed that obesity is having various myriads of the causes, heterogeneity, and that has various pathophysiological causes. And that's why whatever we are trying to treat is actually not that effective, which is available in the other treatment options. Drugs available in the past, we have seen that there were various options available with efficacious medication options also we do have. But we have seen that most of them range right from the amphetamine to the lorcaserin recently, which was withdrawn recently in 2020. We have seen various medications, but because of various side effects, we have to withdraw them. So the problems are there with the therapy and why the pharmacotherapy is so challenging in obesity. We know that there is significant differences in the inter-individual variation related to the weight loss responses. And the development of any effective therapy is again a difficult task because majority of the potential pharmacological targets which are there in the brain, particularly in the hypothalamus, and still with the established ways of drug administration, we still don't have a reliable strategy to enter into that particular area with an efficacious manner. And that's why most of the medications are either having side effect, which is related to the CNS activity, or we are having limited efficacy. According to the FDA, if any medication which has to be approved, that has to be active in form of at least 5% weight reduction in 1 year use, and that has to be at least twice as effective as placebo, or in the treatment group, at least more than 35% of the patient must have achieved more than 5% weight loss. In addition, this medication has produced other benefits also, like improvement in the blood pressure, improvement in the dyslipidemia, and improvement in the glycemic status also. These are other prerequisites. These are the classical slide which we used to read from the DM days, that how there are various new targets like the neuropeptide or agout-related protein, or the POMC card like nucleus. And on one side, there are orexigenic signaling neurons, and while on the other side, there are the anoxygenic neurons, and various actually medication which are being developed are actually trying to target on these. And the impact of PYY, ghrelin, leptin, GLP, or insulins are definitely on these various sites, and that ultimately lead to the development of various drugs. Actually, you can see here that there are various treatment site or treatment target options, and you can see that the most of the medications are actually working at the hypothalamus level or the CNS level. You can see among those various lists, phentermine, topiramate, lorcaserin, naltrexone, bupropion, even the GLP, which has the central as well the peripheral action, leptin analogs, ghrelin antagonist, neuropeptide antagonist, MCR antagonist, cannabinoid, while few like the GLP also act on the GIT, or orlistat on intestine, we know, SGLT2 on kidneys, and GLP has few other actions also. So a brief about the currently available anti-obesity medication which are FDA approved. So here we can see the list because we don't have much time. So orlistat is available. This is approved. Phentermine, topiramate, liraglutide, naltrexone, bupropion. And the newer entrant, which we will discuss in detail, will be the setmelanotide, Gelesis, and few more. While these are the medication which are approved by the FDA, but they are approved for short-term use, and their approval is typically for less than 3 months, and they are among the amphetamine congeners like the doxephedrine, diethylpropion, or amphetamine, or phendiazemetrin sort of medications are also available. Coming to the orlistat, we know, and this is easily available in India also, and the mechanism of action and other actions are already available and known to most of us. So I'm not going into the details, but this is among those medication which is easily available, although the efficacy and few side effects are actually troublesome, and that may lead to the fat-soluble vitamin deficiencies also. Satellistat is again working on the similar mechanism. This is approved in Japan, although not in by FDA, but this has claimings that the GI side effects are particularly 30% less than the orlistat, and the mechanism of action is similar, and the weight loss potentials are almost similar, up to the tune of 3.3 to 4 kgs in comparison to the placebo studies. And they have also shown some improvement in the dyslipidemia parameters also. Phentermine and topiramate extended release preparations are again approved. They were approved in 2012, and they are among the best available efficacious medications. And typically their action is actually by the modulation of various neurotransmitters. Particularly they inhibit the voltage-dependent sodium channels, or they also act on few others. And they have the best of the weight loss potentials, and the side effect profile are typically, because they are related to the CNS, so there are some side effect related, like anxiety or depression, or sometimes the suicidal tendencies also, which we have seen in the medication which we had to withdraw in the past. This medicine is backed up with the good data, like equipped study, like Concur study, which has shown significant weight loss potential, particularly with the higher doses, and which are 15/92 milligram. Although we have to slowly up titrate the medication. Phentermine, topiramate, as I mentioned, they have some CNS-related side effect, but in pregnancy, they have various problems, although they are not approved in pregnancy, but they may lead to the cleft palate or cleft lip in the infant born to the mother if they are inadvertently used in the pregnancy. They might have some peripheral neuropathy sort of problems also, and they might increase the risk of seizures also if in few patients. Naltrexone bupropion combination is again among the best of the medications available, and they actually increase the anoxygenic POMC activity, and they reduce the food intake, and they also has some other actions, like they also inhibit the CNS reward pathways, and that's why they decrease the food intake and increase the satiety. Naltrexone bupropion combination, again, because this is CNS having CNS active action, so they might again have some similar type of problems like depressive symptoms. This medicine is again backed up with the plenty of the data, and they have again shown that there was significant weight loss, more than 5% in nearly 48% of the study population group, and the weight loss potential was significantly better than the placebo. Dosing pattern, again, slowly we have to up titrate like other medication, but we have we should be particular that we should not use in those patients where there is history of seizures and so, and depression, suicidal ideation also there, but they were not much significant. Caffeine and norepinephrine is among the other medication, although they act like amphetamine, but they don't have that much of the side effect. They are actually derived from some leaves, and later on developed in the laboratory. This is the only medication which is approved in Europe, and this is actually approved only for short-term use up to 12 weeks. Liraglutide is recent entrant, and everybody is aware about the liraglutide that we are using for the glycemic purposes, but the 3 milligram is actually indicated by FDA for the weight reduced abilities and potentials. And that has shown to be significantly better than the placebo or the orlistat, and that is backed up by the scale trial, scale obesity and prediabetes trial, scale diabetes trial, and scale maintenance trial. And after those trial results were out, they have given the approval by the FDA. You can see the comparison between the orlistat and liraglutide head-to-head, and you can see that the uppermost, the pink line is actually of on a placebo, while the blue line is actually of the 3 milligram of liraglutide, which has shown the significant benefits. Liraglutide is also backed up with other data where the nearly 66% of the treatment group of patients who were in the pre-diabetes and they were having obesity also, they regressed from pre-diabetes to the normoglycemia within the treatment of 160 weeks. So that was pretty important, that there was a reversal of diabetes from the by the treatment of liraglutide within the treatment of 160 week. And they might be effective in other causes of obesity also, like MCR4 mutations also, but there are few concerns like the MTC concern, or they should not be used where the risk of MEN2 or MTC is there. And there are few reports of diabetic retinopathy worsening is also there. You can see the comparison between the available FDA-approved medication, and you can see that phentermine and topiramate is among the best of the efficacious medication, and you can see the percentage of estimated weight loss, which is best with the phentermine topiramate, followed by the phentermine alone, which is again approved for the short-term use, followed by the naltrexone, bupropion, liraglutide, and lorcaserin is not available now because this is withdrawn and then orally stat. To the newer entrant to this group and the recent entrant into the groups. This is setmelanotide. This is selective agonist of MCR4, and this is recently approved in November 2020 for chronic weight management. And this is interesting to note that this is approved in children's above 6 years or so, suffering from 3 rare genetic conditions, which is the POMC deficiency, PCSK deficiency, or leptin deficiency, as our keynote speaker was discussing about the leptin mutation. Although that is rare, but they are effective, there are treatment options available now. They are also effective in Bardet-Biedl syndrome and Elstrom metabolic or obesity syndrome, but they are not effective in Prader-Willi syndrome. Setmelanotide can be started with 2 milligram, but if not tolerated, then that can be down titrated to lower side. Side effect profile is not much, only some gastric side effect. Although spontaneous penile erections are noted in patient, and there might be some depression or suicidal ideation. One interesting entrant, and this is again approved by FDA, is the medical gastric banding. This is actually the super absorbent hydrophilic gel, and that is actually the cellulose or citric acid hydrophilic gel. And that is inert substance, and this is not a true pharmacotherapy. This is served as the capsules, and there are 3 capsules given as a dose of 2.25 grams before lunch or before dinner with plenty of water, because they will absorb a lot of water. They will swell up to 100 times in the stomach, and then they will reduce the capacity and increase the satiety. And later on, they will lose the water in the small intestine and increase the viscosity of meal, and water is reabsorbed in the colon. This is backed up with the good data of GLOW trials, which showed that in nearly 67% of the study population in the medical gastric banding or this dialysis group, they maintained more than 5% weight loss in the study duration. Abdominal side effect, only the GI side effect are because they are predicted, and the contraindication, they should not be used in those patients who are suffering from any anatomical GI problems or strictures are there. There are a few medications which is already available in the market, although they are not approved classically, but they have significant weight loss potential. The best option is the semaglutide. And we are aware that this will be available as the injection or the oral prep formulation both, and they have significant weight loss potential. And in few trials that has shown that this was even better than the liraglutide, and that reduced the calorie intake by nearly 24%, nearly 700 calories less per day were there with the semaglutide use in comparison to the placebo, and they reduced significant weight loss up to the tune of 3.2 kg. As I mentioned, they were better than liraglutide in that study group, and there is one CVOT is also under evaluation for this. Exenatide, they are also being evaluated for hypothalamic obesity, even in non-diabetic patient. Even without diabetes, other obesity patient, exenatide is being evaluated, and there are various RCTs and meta-analysis which has shown that this is efficacious, although the efficacy might not be that good of liraglutide, but this is also having significantly better results than the placebo. Other like dulaglutide and other GLP-1 analogs are also being used. We are aware about the metformin that not only have the anti-diabetic action, but independent of it, that also act on neuropeptide Y expression, and that also increase the GLP-1 secretion, and that's why that can reduce the weight up to the tune of 2.8 kg at 8-week duration. And with combination of SGLT2 inhibitors, metformin, we are using in clinical setup also, and that has shown in various trials also to be having the potential of weight reduction. Other SGLT2 inhibitors are being used in combination with other medications like phentermine, which is an FDA-approved medication for short-term use. And people have tried to use the combination of canagliflozin with phentermine or with dapagliflozin and exenatide, and that has shown to be efficacious even in non-diabetic patients, and they have this significant weight reduction potential. Dapagliflozin with exenatide, remogliflozin, and sargliflozin were also being evaluated in various patients who were obese without diabetes, and they were also having significant better results than the placebo, although till now they don't have FDA approval. Sotagliflozin is dual SGLT1 and 2 inhibitor, and this is under evaluation for the obesity. Pramlintide, although this is not available in India, but they have this has significant weight loss potential. Co-administration of pramlintide with other medication like phentermine has shown to be very successful in weight reduction up to the tune of 9 kgs or so. Pramlintide with metrelaptine has been used. Pramlintide with calcitonin receptor agonist has been used, and pramlintide with semaglutide has also been used. Interesting part of this talk, emerging drugs in pipeline. So in this particular segment, the researchers are actually trying to use a single molecule which can act on multiple targets. So single molecule on multiple target, or we can say the unimolecular poly-pharmacology approach. And people are trying to use the dual agonist. We know that the oxyntomodulin is actually endogenous co-agonist for GLP-1 and glucagon receptor both. And people are trying to mimicking the efficacy of these two, because the GLP-1, we know that this has various benefits, but the glucagon also has its benefit, like that increases the satiety, that increases the inhibition, that inhibits the lipogenesis, or that stimulate the lipolysis, that increase the energy expenditure by the activation of the brown fat thermogenesis. These are the peculiar mechanism of glucagon, although that has hyperglycemic efficacy. But if you are using with GLP-1, then this is nullified, and this combination as a whole will be useful to treat the obesity. Various molecules are under phase 1 or phase 2 trials, and which are actually targeting the GLP-1 and glucagon receptor, and they are dual agonist. And they have tried in various phase 1 and phase 2 and shown to be very efficacious. Agonist means they are trying to target GLP-1, GIP, and glucagon, all three receptor. As I just mentioned, that GLP benefits we are aware, GLP-1, glucagon, as well the GIP triagonism has also been found in the initial preclinical or the clinical trial to be efficacious in metabolic or obesity disorders. Briefly, these all triagonists developed so far has shown unmatched result regarding the potential of inducing weight loss in preclinical studies. This approach, by targeting all three receptors at the same time, could be able to pharmacologically mimic the physiological effect of bariatric surgery. So the results are actually exciting. If this trial are successful in the advanced stage, like in phase 3 or so, then they will be as good as the results from the bariatric surgeries. So the results are really exciting. People are trying on twin creatines also, like GLP-1 and GIP. We know about the GLP-1. GIP physiology is actually controversial about the weight management, or this still remains the investigational. But the combination of GLP-1 and GIP, which is actually the agonist, also has shown to induce significant weight mass reduction and improvement in insulin sensitivity and glucose metabolism. The one name of such molecule is tirzepatide, that actually has much GI side effect like the GLP-1 receptor agonist. And in phase 2 trial, that has shown to be significantly having improvement in glycemic control and dyslipidemia and body weight. There are various few other molecules also being evaluated. Few interesting targets like peptide-mediated nuclear hormone delivery in future. We know that these all GLP and that all are actually the peptide hormone, while the estrogen, like the thyroid hormone or the dexamethasone, they are the nuclear hormone, and they have their own benefits and the problems. But if we are able to combine these two, then estrogen, as they will act on the nuclear receptor, they will be beneficial and they will be useful in replicating the effect of GLP on the nuclear level also. And the GLP-1 with estrogen has shown to be proving the promising results in correcting obesity. And in the mouse model, this combination of GLP-1 with estrogen conjugate has to be shown to be very efficacious up to the tune of improvement in 10% or 23% of the weight reduction. Similarly, the glucagon with thyroid hormone has been tried as a conjugate. And as the thyroid hormone is acting on nuclear receptors, and this combination is again has shown in the preclinical data to be significantly effective in reducing the food intake and in increasing the body energy expenditure. And the side effect profile is reduced. Similarly, the GLP-1 with the dexamethasone conjugate has also been tried. And this conjugate has actually shown to lower body weight up to the tune of 25% in rodent model, while by targeting the hypothalamic control of food intake and increasing total energy expenditure. So these all are actually bypassing the typical deleterious effect of dexamethasone or thyroxine or estrogen, while they are providing the benefits of the glucagon or the GLP-1 receptor. Peptide YY is another molecule which is being tried, as we know that after diet or after postprandial status, we know that there is a release of peptide YY, and this is a mediator of satiety. And the most effective form of peptide YY is from amino acid 3 to 36. And this is the most effective form which act on hypothalamus, and this inhibit the orexogenic neurons, neuropeptide YY, and that actually activate the anorexigenic POMC neurons, and that suppress the appetite and that enhance the weight loss. And the combination of GLP-1 with the peptide YY has been used, and they had equated to the medical gastric bypass therapy. Previously also we discussed about the medical bariatric surgery, and this is also having the similar sort of potential, although the data are preclinical or in early stages of trial, and we have to wait for the better results. But they are being currently evaluated with combination with semaglutide, combination with liraglutide also, and one molecule is in peptide, and the studies are going on in the Denmark and Sweden in phase 2 also. Various other molecules are also there, but because of the lack of time, I will not be able to discuss those all. I will just name those, like few, like methylphenidate. This is a dopamine reuptake inhibitor that also are being evaluated in phase 3 trials. Tasofenicin, that is norepinephrine, dopamine, and serotonin transporter inhibitors. They are again in phase 3. Oxytocin, interestingly, this is intranasal preparation, and this has shown to be centrally acting, and this is useful in hypothalamic obesity, in sarcopenic obesity, and they are in phase 2 trial. With pioglitazone, mirabegron, which is beta-3 adrenergic agonist, are also being evaluated in phase 3 trial. Few more medications are also there. Interestingly, the typically used medication of tadalafil and sildenafil in the erectile dysfunction are also being evaluated for the obesity purposes. The combination of leucine, sildenafil, metformin are also being evaluated, while as we have just discussed about the medical gastric bypass options of peptide YY and GLP-1 analogs. Cannabinoid receptor, we know the Raymond story, that how the suicidal tendencies actually lead to the withdrawal of the medication. But the peripherally acting newer molecule on which is working on cannabinoid receptor are also being evaluated to treat the Prader-Willi syndrome. This is in brief. Just to conclude, that we know that various challenges are there to development of the obesity pharmacotherapy, because there are myriads of genetic, developmental, biological, environmental, or behavioral factors which are operating in the obesity pathophysiology. Many options were there, but although they were efficacious, but they were not safe and has to be withdrawn. But newer approach like unimolecular polypharmacy, mono, dual, or triagonism, as we have just discussed, are showing promising results, and they will probably open new avenue in the pharmacology of obesity management. And probably if the results are favorable, then we will be probably at the end of dark tunnel of this obesity management, particularly regarding the pharmacotherapy. But still we must emphasize that the motivation, the modification of lifestyle, and support from the physician and as well from the family is key to the success of the treatment. Particularly, we have